What is rehab or rehabilitation? My name is Fred Begaris, a board-certified sports and spine medicine physician in Virginia Beach, Virginia. After 10 years of practice, I still find musculoskeletal medicine both fascinating and challenging. This podcast is about the lingering thoughts and questions I've had after residency and fellowship. My hope is to spark discussion, challenge dogma, and share my experiences in musculoskeletal medicine. Welcome to the Talking Rehab Podcast. Hip and spine syndrome is one of my favorite conditions to see and talk about. It was described by Oforeski in the early 1980s, and essentially it is a very common condition that I actually feel is underappreciated, where a patient has symptoms of stenosis of the spine and or hip/groin pain related to underlying osteoarthritis. What makes it interesting is that some people have kind of a variety of symptoms. So it can present in a number of different ways, and it can be very challenging not only to diagnose but also manage. One of my very first patients I saw that I started to gain this type of appreciation had a combination of back and hip symptoms. I actually first met them to help them with their musculoskeletal complaints after they had a back surgery. And the surgery helped them, but they still continued to have essentially pain, not just in the back. It was also in the butt, but it was also in the groin. And they saw a number of different specialists. They tried different medications, kind of the usual story. And eventually, when I saw them, I realized that the main problem was their overall posture. They were kind of hunched over, but I believe most people just assumed it was because they had back pain. But when I actually examined them, I realized that they just physically could not straighten out. And it was a large portion to their hips. The hips were not moving really at all. And when I eventually ended up getting x-rays of their hips, it was just a crazy amount of arthritis in the hip joints. But what made it interesting was that their predominant symptom was more of kind of nerve/radicular pain. But they also had flashes of groin pain. So it's a very confusing condition to diagnose and manage. And I've seen it present in a couple different ways. Some people present with predominantly back pain with no leg symptoms or groin symptoms. And I've seen people present with predominantly stenosis symptoms. Your classic standing and walking causes pain down both legs or weakness. I've also seen people present with back pain and groin pain, and people with purely groin pain. I've also seen people present with lateral hip pain, which again is even more confusing. So as you can imagine, when things present this way to your primary care physician, it can be difficult to help create a rehabilitation plan, because I believe we all want simple conditions, just one condition. But in this particular case, there's a number of different presentations. So depending on what symptom presents first, it really sometimes dictates the referral patterns from there. So as an example, if someone comes in with predominantly butt pain symptoms, they might go see the orthopedic surgeon or the pain specialist or the spine surgeon. If someone comes in with predominantly radicular symptoms, usually they go to the spine surgeon. And this sometimes presents a problem because I believe that hip and spine syndrome is underappreciated. It always makes me wonder how often people are actually looking for it. I'll give you an extreme example. I had a patient that had severe groin pain, and very classic standing, walking caused very localized groin pain. And you examine according to the notes, they saw a orthopedic surgeon, hip examination was classic, positive Faber's test, positive log roll, limited range of motion. Everything seemed to line up. X-ray demonstrated severe arthritis. And so they went on to have an uncomplicated hip replacement. Hip joint looks, or the prosthetic joint looks perfect. However, the pain never changed even for a second. And so they went through the post-operative rehab portion of things and did just fine with the counseling that, it takes time for this to resolve. And eventually they got to the point where it was 3 to 4 months. They had finished the rehab and the surgeon was like, well, everything looks fine from a prosthesis standpoint. So at my first visit, their hip moved excellent, but the fact that their pain never changed, that always leads me to think that this may be a referred pain pattern. And I ended up obtaining imaging with an X-ray and an MRI, and eventually I diagnosed them with an L2 radiculopathy. I ended up doing an epidural injection targeting those particular regions, and it actually improved their pain like 100%. And it was kind of an awkward conversation because, of course the patient was like, well, that was a waste, and but at the end of the day, it's a hard condition to diagnose, and I would argue that it actually wasn't a waste. A part of the problem with hip and spine syndrome when there's underlying arthritis of the hip joints is that it changes the way that people move. In this particular case, even though the hip joint was replaced and the pain did not go away, the fact that they are now able to move more freely and work and move in a more normal plane, it actually improves their back symptoms. And this has been shown in the research where people who do have predominantly hip osteoarthritis pain and have back pain, just regular back pain, not related to stenosis, just have regular back pain. After a hip replacement is done, a large majority of people report improvement in their overall back pain. That always, made me kind of curious whether or not it was the chicken or the egg. And even though the hip is a very simple or quote unquote relatively simple joint to replace, it gives you immediate feedback in terms of pain improvement and gait efficiency, significant improvement in the quality of life. But again, this was a very interesting case where someone had no improvement, and it's hard to say whether or not it's the chicken or the egg. Perhaps the L2 radiculopathy produced pain or weakness, causing the person to hunch over, change their mechanics, and contribute to the development of osteoarthritis of the hip, or vice versa. Someone who has an arthritic hip has a tendency to flex forward, rotate their hips outward, shortens their gait. Their gait is generally asymmetric, and all of those movement features contribute to degenerative disc disease. So it can be very challenging. I've had also patients that have very classic stenosis type symptoms, improves with an epidural injection. And the question at that point is, well, is this now a surgical problem for the spine? And anytime I see people with that picture, I always image the hips, even if I have a very small suspicion of any arthritis at the hip. The reason is I want to know all factors before I make a formal recommendation. I remember having a patient several years ago where they had very classic stenosis symptoms, responded well to an epidural, did physical therapy, but had limitations, ended up having a spine surgery, did really, really well. Usually after spine surgery, people are discharged around the 3-month mark. However, around the 9th month, they came back to me saying it didn't work. And so when I said, "What do you mean it didn't work?" They said, "Well, I'm still in pain." And the more that I probed, the pain that they were reporting was in a completely different location. And when I went back through their history, I noticed that they did have evidence of decreased range of motion of the hip. And eventually I ordered a new x-ray, which demonstrated arthritis in the hip. And this was, kind of a interesting find from a physician standpoint, but this was obviously frustrating for the patient because here they thought they had one problem and they actually had two. And even their perception was that the initial surgery of the spine didn't improve anything because they had persistent pain, even though the the two factors are, kind of unrelated from the patient's experience. They didn't feel like the surgery was worth it. And I started for that reason looking for these type of factors. If I have someone with predominantly groin pain, I look for back related stuff and vice versa because it's part of the counseling. I think that I've seen a lot of patients get frustrated with persistent symptoms after they've been discharged from surgery, and they kind of feel like they have to start all over again because it's like, well, that had persistent pain, that even though the back surgery went really well, I went to see my spine surgeon. The spine surgeon said, no, the surgery site looks fine. Go back to your primary care physician. The primary care physician then says, oh, it looks like it's your hip. Go see the orthopedist. And, while the patient eventually gets to the right person, I think it is better if one person is looking for both conditions and then kind of triaging from there. It just makes the overall experience, I think, much more streamlined, less frustration by the patient, and ultimately an overall better outcome. Anytime you have someone going through a medical condition with frustration, you have to manage that because if you don't, the outcomes almost always are not as good. The last anecdote is I had a patient recently that actually presented with lateral hip pain with intermittent numbness and tingling in their foot. They ended up having evidence of both, again, arthritis of the hip with stenosis of the spine. And the they responded, excuse me, they did not respond at all to the epidural steroid injection. And eventually they went back to the surgeon and they just said, well, it's not your spine because you didn't respond to the epidural. So go see either your pain specialist or go see your primary care physician. Um, they ended up seeing the orthopedic surgeon, and while they had x-ray evidence of arthritis, the pain location for the hip symptoms was not really in the anterior aspect of the groin. It was more of the lateral aspect of the hip, which again is not a classic picture of osteoarthritis. However, there have been studies that while the more common location is the anterior groin, there is maybe a 20% of the population that presents with lateral hip pain when they have underlying hip arthritis. So because this particular patient didn't present in a classic fashion, the orthopedic surgeon just said, well, go see the pain specialist. So they ended up kind of somewhere in limbo. They weren't quite spine enough, they weren't quite hip enough, and they were just kind of left out to fend for themselves. But again, I think it's a really, from a musculoskeletal standpoint, it is a great condition to learn and also to manage because the unfortunate truth is that most specialists only look at one area and they only want to talk about one thing at a time. That's not really very efficient care, which is why I don't practice that way. I tend to look at everything. But if you're out there listening and you have kind of a hodgepodge of symptoms, or you're a clinician and you have someone that presents in a very similar way where it's like, well, is it the hip or is it the spine? Please consider hip and spine syndrome and triage them appropriately. The neck and shoulder has a similar presentation, and I'll probably do a podcast episode about that because the neck and the shoulder, to me, is actually much, much more difficult to differentiate. So, anyhow, hope you guys enjoyed this one. Have a great week. Thank you for listening to the Talking Rehab Podcast. I hope that this podcast stimulates you to question your own practice and how you approach rehabilitation. I truly appreciate your time and attention. If you enjoyed listening, make sure to like and subscribe to the podcast. I wish you a movement-filled day. Take care.